morning, everyone. I want to welcome everyone to our Healthcare Roundtable focus on women's health and cancer awareness. I want to first of all thank our partners, UTMB, MD Anderson, and Community Health Network for taking your time out and coming and giving us some great information, informative information that our women need on this day. So I'm going to turn it over to Noelle Benavides. She is our ambassador for our chamber. So just want to, Noelle, if you want to go ahead and take it over.
Yes, good morning. Buenos dias. I know you guys probably don't speak Spanish, but I'll be kicking in some Spanish here and there, just for those people that are listening. First and foremost, welcome. And like Gina said, thank you so much for the time that you are taking to give us, help us with information. I will have a few questions for each and one of you to answer. And this will be, because first, like Gina said, it's being recorded. And we want to keep this information handy for our communities. A lot of times people go into our website, and if for any reason they missed the meeting, at least they can get some information and what's the important things to be aware of, and then who to contact in case there is something going on. But again, thank you so much for your time. And I will begin by introducing or allowing you guys to introduce each other. Dr. O from MD Anderson Cancer Center, can you please just give us, we want to give you a warm welcome and share with us some of your information.
Good morning, everyone. Thank you so much for creating this forum. I think this is a wonderful avenue to get information out there. I'm a breast imaging radiologist and associate professor of radiology at MD Anderson Cancer Center. I'm actually based out of the Woodlands, and one of my passions is education. So I'm very excited to be able to participate in community education today. Thank you for having me.
Thank you so much. Awesome. And we also have Dr. Poindexter from the Community Health Network.
Hi, good morning. Thank you again for having me in the forum today. I love, to be able to get out there in the community, meet people where they are, so that we can be more informed about this specific month and just ongoing for breast cancer awareness. I am the Chief Medical Officer for Community Health Network and have actually been here for almost 13 years, which is awesome, right?
Yes,
and so
yes, it is. Thank you.
Yeah, I love my community here in Brazoria County. And we also reach Galveston and Southeast Harris County. And I'm just glad to be here today.
Welcome. Thank you so much. Dr. Elijah, it's your turn. Am I saying that correct? Elijah Jackson?
It's Alicia.
Alicia
Yes.
Jackson.
Hi, I'm Dr. Alicia Jackson. I am a urogynecologist and reconstructive pelvic surgeon, and I'm fairly new to Brazoria County and to UTMB. Started in July, and just thankful and happy for this invitation to speak to you all about just women health issues that I can help address.
That is awesome. I do have a few questions for each and one of you. And then towards the end, probably one of the things that we'll want to do is make sure that everybody has either an 800 number or somehow that if somebody needs to get a hold of MD Anderson or the Community Health Network or the UTMB, there's either like a hotline or 800 number where people can reach out. Okay, so I will start with the Community Health Network questions. Dr. Poindexter, what is the best way to prevent breast cancer?
Well, I am an obstetrician gynecologist, board certified, and so it's just been keeping aware, of breast cancer and the changes that we've gone through over the years, my 24 years in practice. So I'm sure that they'll explain a little bit later, especially our expertise from MD Anderson, but there are different factors that play into the beginnings of breast cancer. And a lot of times we don't know breast cancer begins, about, it might even 2 years, 5 years before we even notice a breast lump. So there are environmental factors that can play a part, a role in breast cancer, as well as genetic factors. And so we as women, some of the things, there are a long list of things that we could do to prevent, and we could talk about that a little later to help prevent it. It can, you know, from changes in behavior, from changes in diet. But, you know, one of the things I encourage is that, you know, women do get in for their annual visits. We call it a wellness exam now. I don't, you know, we used to know the term pap smear, come in for your pap smear. Well, I want to say it's a wellness exam because there's so many different preventions that we can perform during that wellness exam for women, and breast cancer awareness is a part of it. There have been different recommendations as far as over the years, as far as mammograms. Now, you know, it's recommended mammograms that routinely at age 50, 40s, you can start for mammograms, you know, with a shared decision with your provider. But then you also have people who are at higher risk that mammograms might not be enough. We might need MRIs, we might need gene testing. So it's a whole gamut, but I think, you know, if you get in for your wellness exam and you're aware of your breast every day, not necessarily self-breast exam, we don't necessarily call it those in this, but just to be aware of what's going on with you and your breast, we can help, you know, talk about a lot of these things that could be prevention, as well as providing prevention and being proactive in your care.
Now, do you guys there at Community Health Network, you do provide mammograms?
We do provide mammograms. We actually collaborate with the Rose. I love the Rose. I've been a proponent of them for years through practice. And one of the reasons why is because, you know, they do receive a large amount of funding. So those women who may not, that are uninsured or underinsured, they're able to receive screening mammograms through them. And they also help to navigate your care. So I find when I work with some of the other places, like just an individual imaging opportunity, you know, you might not get to navigate your care so and undergo education. And of course, you know, I know UTMB and MD Anderson have services as well, but we as a federally qualified health center, community health center, they come out to our site in a mobile, which is really nice. They come out monthly, and you are able to receive a mammogram. We can get you scheduled. Normally, it would require, you know, for you to come in for a visit, and you can establish care with us as well. We have other services. We also, not only women's health, we do primary care, provide primary care, behavioral health and mental services, as well as oral health services. So there are different opportunities for prevention. And we really care for the holistic or the whole person, and believe in integration of care. So if you come to me for a wellness exam, I'm going to talk about the whole gamut, your emotional being, everything.
We should walk out of there just looking really good after a visit with you all.
That'll be our next edition, right?
Yes.
A wellness center. That's what I'm looking forward to. Yes.
So let's say that I'm not a patient with Community Health Network, but I want to schedule a visit for just the mammogram. Is that possible as well?
Yes, you may schedule one. However, again, we would ask you to have a consultation with a provider. Does not have to be me as the OB-GYN. You may have your own OB-GYN, and that's okay. We can do virtual visits as well, remote visits, in case. But the mammograms right now are located at our main location. They come into Freeport, Alvin, and at Pearland. So we could get you scheduled at any of those sites.
Okay, gotcha. Okay, now I have questions for MD Anderson. Of course, like I said, I'm Hispanic. I was born in Mexico, but raised in California and then brought to Houston. My question would be, what is the most common cancer in Hispanic women, and what signs should she look out for?
Thank you so much for the question. It's actually right on the nose. The most common cancer at this point diagnosed in Hispanic women is breast cancer. I think that for a long time, people realized that the rates of breast cancer in Hispanic women was lower than what was being seen in non-Hispanic white women. And so there was a certain comfort in that. But things are changing. We're seeing an increasing incidence of breast cancer being diagnosed in Hispanic women. We also find now that, very sadly, the most common cancer death in Hispanic women is breast cancer.
Wow.
And this is something that's important to discuss because breast cancer treatment is growing by leaps and bounds. We are becoming more and more capable, more and more equipped at being able to treat breast cancer when it's caught early. And so it's very important, I think, for Hispanic women to realize that they do carry a risk of breast cancer. Every woman does. And it's important to try to get it caught as early as possible when it is the most treatable with the least amount of grueling, taxing treatment.
What's a good sign, or what signs should they look out?
Yes. So for the purposes of breast cancer, we always want to consider your breast and your underarm. Okay. So people can call it your axilla. You can call it your armpit. You can call it whatever you want to call it, as long as you're also keeping track of it, okay? So that means that you need to be aware of lumps in the breast or in the armpit, okay? That can also be a sign of breast cancer. You need to be aware of skin changes. If there's redness, if there's thickening of the skin, if the skin starts to look so thick that you can see the pores standing out like you would see in an orange, we call it the peau d'orange, that could be a sign of breast cancer. If you see changes such as in the nipple, such as your nipple being pulled away from the direction it usually goes in, if it's being pulled inward, so it's retracting, if it looks like there's a slit in the middle of the nipple that's pulled inward, if you see discharge from the nipple, especially if that discharge is bloody, you're finding some bloody discharge in your bra or in your clothes, if you're seeing scaliness on the skin, especially around the nipple. Some people describe it almost like an eczema, but it doesn't go away with just lotion. It's persistent. Any of those symptoms that last longer than 2 weeks, it is important to let your doctor know and to have that evaluated with imaging. Mammogram, sometimes also ultrasound, sometimes also MRI. And I want to point out that breast cancer can also affect men. And the signs of breast cancer in men are the same. And what we find is that a lot of times the reason that breast cancer is diagnosed in men is because of the women in their lives. The women in their lives will say, there's something happening with your nipple there. There's this lump here that's sitting in your skin. What is this redness, when he takes his shirt off? So as women learn these signs and symptoms of breast cancer for themselves, also keep in mind that you may end up being the gatekeeper. You may end up being the steward, the guard for your family and loved ones.
Yes. Yes. How often should a woman get a mammogram, and after what age?
So this is one of those questions that it's very important to discuss. And I want to be very clear. While there have been many different organizations that have come out with different recommendations about the age to start screening, some have said 40, some have said 50. It is absolutely clear. All of these organizations will agree that the most lives are saved when women begin, average risk women begin annual screening mammograms at age 40. That saves the most lives. So you can have different other reasons for saying, let's delay it for some women and all of that. But the truth is that for the most lives to be saved, we absolutely recommend that average risk women begin screening at age 40. But 40 is the latest age that you should begin your screening. There are some women who are at higher risk for whom they should actually begin screening in their 30s and sometimes in their 20s. So how do you know if you fall into one of those categories?
Exactly.
Exactly. So we're going to talk about this. If you have a family history of breast cancer, so you have mothers, sisters, aunts, grandparents, especially if it's in the same line. So if you're seeing the same, your mother's family seems to cluster breast cancer. If you're seeing a family history of ovarian cancer, there can be an association there. If there is a history of male breast cancer in your family, that also increases your risk of breast cancer.
Wow.
Then we also can see some personal reasons why a woman would be at high risk. If you've previously had a biopsy and the biopsy showed something we call a high-risk lesion, it's an atypia. It's sort of the saying that your breast has the ability to grow precancerous lesions or cancers. Those women could be at high risk as well. If there's a family history of a BRCA gene mutation, you may have heard of this, the BRCA1 or BRCA2 mutation, and some other familial gene mutations. These are some of the things that would increase a woman's risk of breast cancer. And so for these women, we recommend that they have a conversation with their healthcare provider before the age of 30 to determine when their screening starts. Some of them will start screening in their late 20s with ultrasound and MRI, and some may start screening mammograms in their 30s. We want to start screening way before the risk of developing a breast cancer. So if the family member, if the youngest family member who was diagnosed, let's say at age 45, then we give you 10 years prior to that to begin screening. So by age 35, then the women in that family should begin screening because we want to come ahead of the curve to be able to catch something. But it's important that each woman have a discussion with their healthcare provider, weighing their particular risk so that they can make an informed choice, not one out of fear, but an informed, confident choice about how to approach their breast health to maintain their health as long as possible.
Yes, absolutely. That's very, very important because I know that a lot of times, especially in the Hispanic community, it can be because, oh, they're too shy, they're too embarrassed, they have a communication barrier. They may not even have insurance. So I know that what Dr. Poindexter said about the rows, that's great information for those people that say, well, I don't have insurance or that kind of stuff. And so also there's, I know I've heard of the 3D mammograms. Are those good? Are those recommendable? Are they in better favor than the typical mammogram? What's the difference?
Absolutely. I'll come to 3D mammograms in 1 second, but if possible, I'd like to address something that you said. There are certain things we see more commonly in Hispanic women, like you said, slower reporting of symptoms. Sometimes it's cultural, people are very private. We also see that there's more likelihood that they don't follow up on abnormal test results or the insurance issue. I want to empower everyone here to please know that you have no bigger support than the physician. Maybe I need to speak for myself. You have no bigger supporter than I, okay? We want to meet you where you are. So however you need to communicate the information, we are ready to receive it. I've had people write on a piece of paper because they were too shy to say it. I am seeing, blood coming out of my nipple because they couldn't form the words. That's okay. We are fine with that. We are happy to hear the information from you any way that you can. But this is what I do 100% of my days. So there's nothing that you're going to see or that you have experienced that I'm not comfortable talking about. This is all I do, okay? We are very, very comfortable with addressing these questions with you in a way that is respectful and preserves your modesty, okay?
Awesome.
I will say that we absolutely believe that 3D mammograms are more effective than the 2D mammogram.
Okay.
Both sets of mammograms, 2D and 3D, just require X-rays. It's a very, very low dose X-ray that is able to penetrate the breast tissue and give us an idea of possible signs of an early cancer. 3D mammograms, though, take a series of tiny pictures from different angles all around the breast and basically creates a reconstructed view, almost like a 3D view of the breast. So it's a bigger picture with more detail. The research shows that with 3D mammogram, we're able to see a lot more cancers in women of every age, of every breast density. It's more sensitive. But we also see that with 3D mammograms, we reduce the chance of what we call a false positive callback. So we're able to see things that may mimic cancer, but more closely say, this is not cancer. And so you don't get a scare. You're less likely to get a scare if you're using a 3D mammogram. It's just more accurate and more sensitive. So it's a technology that I recommend for every woman who's obtaining a mammogram. It can be done at the exact same time as your mammogram. It only takes a few seconds more per image. It does not significantly increase the dose, but what it does do is give us a better chance of diagnosing cancer early for any woman undergoing mammography.
Awesome. And I would say that this question is for all three facilities. Pretty much, I'm pretty sure everybody has somebody in y'all's department who speaks Spanish in case the women say, well, I can't go because I don't understand what they say. Who's going to answer my questions? I don't have an interpreter. So we're trying to break every barrier that can be in their mind or in their way to make sure that this prevention and this early detection gets done, because we know that there's more hope at that point.
Absolutely.
We have team members from scheduling, mammography, the ultrasonographers, and we have a translation line. So we have a lot of access to people that can help you feel comfortable if you want to communicate in Spanish, and we can do that so that you're heard, you're understood, and you feel empowered at the end of the visit.
Awesome. Thank you so much, ladies. That has been great information about the breast. So I think it's also such a major blessing to have Dr. Jackson, because she's now can you tell us what is your title? I'm trying to, you're a gynecologist or pelvic reconstruction surgeon. And I know that a lot of women right here, right at menopause, I haven't started having any, praise the Lord, any urinary tract infections, but I know that it's very, very common in women. So the question would be, what can be done about women who have recurrent urinary tract infections after menopause?
Awesome. Thank you for the question. And I'm happy we're in this setting because the main treatment to prevent urinary tract infections after menopause, exactly what you said is very common, is vaginal estrogen cream. It's a very simple and easy fix, but it's sometimes shied away from because of people's concern with estrogen and breast cancer. They've made that connection erroneously to believe that any type of estrogen is going to put you at risk for breast cancer. But for recurrent UTIs, that's the treatment of choice to prevent these terrible, bothersome infections, because the environment of the vaginal tissue has changed after menopause. And because of that, the infections are more likely to travel to the bladder, and that barrier or that protection that you have in the vagina with the good bacteria are now moved out or gone away because of the lack of estrogen. So you replace the estrogen, restore that environment, you can see a decrease in urinary tract infections after menopause. The question I often get is, are patients who have a family history of breast cancer or a individual history of breast cancer, they're concerned about any form of estrogen. So I reassure them that this is localized therapy, is topical. The support of my society, the American Urogynecology Society, as well as the International Urogynecology Society, in partnership and along with ACOG, or the American College of Obstetrics and Gynecology, support low-dose vaginal estrogen cream as a therapy in women with a personal history of breast cancer as well as family. And from my standpoint, I try to reassure them of the mechanism and how that will work and how it stays localized. However, I always encourage them to speak with their oncologist so they get that extra blessing, because of course, when patients have a personal history, it's very, very sensitive subject for them to even use any type of estrogen. So that cream will allow you to, you place it vaginally, and it allows that environment in the vagina to be restored so that you can prevent infections in the future. I also want to note that recurrent urinary tract infections is defined as 3 or more infections proven by culture, urine sample, in a year, or 2 or more in 6 months.
And now when it comes to that cream, will they have to go have a consultation with the doctor, or is that something that they can buy over the counter?
Great question. That's in consultation with your doctor. And we will prescribe that, as well as give you the instructions for use, because it's important to use it properly and to use it as prescribed. So it's definitely something that we can prescribe, and that is usually covered to some degree by insurance. It can be, depending on the type of insurance, expensive. So there's other options in terms of compounding pharmacies, in terms of copay assistance plans, things that can help people to be able to get this medicine and be able to afford the cost.
And that's awesome information. The fact that 3 urinary tract infections in a year, or 2 in 6 months, is considered a recurring, because a lot of people think, oh, I'm not drinking enough water. I know that that's kind of like a myth. I'm not drinking enough water, or I need to drink cranberry juice and I'm going to get it done and over with. So what can you say about that?
Well, it's definitely something that is usually overdiagnosed by like the patient, because I always tell patients that there are signs and symptoms that are the infection or urinary tract infection, but there also can be inflammation there, where there's the absence of a microbe or a bacteria, but still having these same symptoms. So that's why it's important to have the urinary culture done, so we can see and prove that it is truly an infection and treat you appropriately. So that you are either getting antibiotics because you need them and to eradicate the infection, or you're not using them improperly or inappropriately, the antibiotics.
Gotcha. Awesome. The next question I have for you, Dr. Jackson, is what are pelvic floor disorders?
So pelvic floor disorders include urinary incontinence, where you leak urine where you don't mean to, you don't make it to the bathroom. I always tell patients, you got to get there, you don't quite make it. There's what's called stress urinary incontinence, where you leak with certain maneuvers such as coughing, sneezing, laughing, exercising, sometimes even during intercourse. And then there's urinary urgency frequency, and waking up at night with the urgency to go pee or go urinate. That is called overactive bladder. And that again is where the bladder is just contracting when it wants to, instead of listening to the brain to tell it when to at appropriate times. And then there is pelvic organ prolapse, which is a disorder where patients literally feel that something's coming out of their vagina. And it's vaginal tissue that is descended lower. And I always compare it to like an inside out glove or sock, where the glove has now everted outside of the vagina. And now you can actually feel this bulge, or as my Hispanic patients call it, bolita, in the vagina. And they notice that they feel like they're sitting on something like an egg, and they report it. And I always tell them that I'm just here to confirm that and tell you how it's treated. Also under that umbrella is accidental bowel leakage for pelvic floor disorders, where people leak stool when they don't mean to. And also there's the recurrent UTIs or urinary tract infections, and then painful bladder syndrome, which is where patients don't have infectious processes, but inflammation. And that causes them to have pain in the presence of urinary symptoms. So those almost like 5 things that fall under that umbrella of pelvic floor disorders.
And obviously, I'm assuming that these are a lot more common after menopause?
They're more common as we age, yes. They're more common after menopause. They're also, all of them have some factor in obesity being a risk factor, which we know is a pandemic, definitely an epidemic in our country, where we don't discuss it enough, in my opinion, and it's hard to give patients the instruction on that, because they need a plan too. Obesity, chronic cough, those are other risk factors that do contribute to all of these.
So who can to if I have concerns about urinary symptoms?
So
Regular
the-
doctor, do you recommend
Mhm.
that we specialist?
So many studies have shown the importance of screening our women so that they are able to know that they can talk about this. It's very embarrassing for patients, and we know from various qualitative studies that patients will not talk to their providers about it. So it's important, especially at the primary care level, to ask the patients or to screen them. Are you having any problems with urination? Are you having any problems with bowel leakage? And so that you can start that conversation. And then if you are familiar with these disorders as a primary care provider at wellness visits, it's great if you can start with physical therapy consultation as well as medications. But if you're not comfortable with moving forward any treatments, it is very, very appropriate, and we're very happy to take them on as new patients in the urogynecology clinic, and we will get their plan of care started and get them treated.
This is such great information because, like I said, coming myself being Hispanic, I know that the women are so quiet. I know that they're so embarrassed to say that, I had a sister-in-law, of course, this was because of her pregnancy, and she was young, and it was actually her first pregnancy, and she was already almost due, and she would sneeze and she would lose some urine, of course, because of the baby pressing on. And we would laugh. And she said, don't laugh. It's embarrassing. And it's like, you know what? It's because of those situations that people rather not say anything. That, of course, in her case, we know she didn't have a problem. All she had was a heavy baby pressing on her bladder. But at the same time, now that I have gone through menopause, it is in the mind, or in my mind, what I would ask myself is, what in the world is my body going through? Because there are so many changes, so many things. You always wonder, is this normal? Is somebody else going through? Gosh, I better not say anything. Maybe it's just me. And yet we sit down with you all as professionals, and it's like, hey, we see this on a regular basis. We see this every day. This is not normal. This is the most typical thing. So then what is it that stops us from sharing or saying what we have? Is like, oh my gosh, it's probably just me, and yet, like Dr. Owen, like Dr. Poindexter said, it's always so crucial, the timing of the symptoms. It is very, very important that people would say, well, this isn't normal. Yes, I know I may be going through menopause, but I don't know if this is a normal reaction of the body because of menopause, or if it's a red flag that needs attention.
Speaking to your point about your sister-in-law and things to prevent this from worsening even past or beyond her pregnancy, because she can still see that after pregnancy, regardless of route of delivery, you're at risk just from pregnancy of urinary incontinence and pelvic organ prolapse. But to speak to your point in terms of prevention, if you mention it to your OBGYN, they can help you with physical therapy, pelvic floor physical therapy, because multiple studies have shown that doing learning and doing these exercises properly can prevent your symptoms from worsening beyond pregnancy. Learning earlier on, in many other countries, pelvic floor physical therapy is part of their postpartum care, that after they've delivered and everything is healing well, they go into physical therapy just to help strengthen these muscles and help with this large insult of the pelvic floor after delivery, and try to rehabilitate the pelvic floor. So it's important to be a part of the earlier stages of our lives if we can, so that we have a chance to not get into these worsening situations as we age.
That is absolutely fabulous information, because I'm talking to you back in 1989 when she had this. We're now 2021. And now that she's older, because I'm 51 and she's older than me. Now I notice that if she needs to go, she holds herself like, I need to go. And that's fabulous information, because I need to ask her, have you talked to your OBGYN to make sure that there are things that you can do, the physical therapy that will probably help you this, instead of running to the bathroom with your hand where you're not supposed to, because you're like, I don't know if I'm going to hold it or not.
Yes, absolutely. Absolutely.
That's great. See, I mean, it's through these forums that, and here we are, because they're all Spanish speaking. I always tell her, did you tell your doctor? And I always make sure, hey, when they talk to me, it's like, does your doctor speak Spanish? These kind of things you need to make sure that you are clearly communicating it to them, because if it's through a translator, you may be able to lose something, especially if the
Absolutely.
translator is not a person from the doctor, because the person at the doctor's office, they're constantly hearing these things and know exactly what the response is going to be. But if you're just taking somebody with you to translate, there may be some loose or miscommunication there that you won't receive the whole grasp or the whole information of what you should have received.
Absolutely. We have interpretive services, as the doctor mentioned, and that's very helpful. But I do agree that you don't always get the full picture with those limitations. That's why just speaking to the like a social science study approach in medicine. That's why it's important to see yourself, right, and your doctor, so that you have that understanding. Correct. You're able to have those language commonalities, because things can get lost across cultures, across ethnicity. So I agree with your point.
Awesome. Well, I'm going to have a question for all you three, and I'll start with Dr. O from MD Anderson Cancer. In your opinion, and based on what you guys have seen and all of your studies, what are the actions a woman can take to reduce the breast cancer risk? I mean, we did talk about the importance of, if it's coming down the bloodline through your family or whatever, that's one thing that you need to stay on top of. But what can be other, reducers for the risk?
So so there's a few things that are within your control, but not all of them. Okay. So take what you can and don't feel pressure. Okay. So it's very important that for all women, you have a lifestyle that includes activity. We say 150 hours of moderate activity per week. So that's walking. Or if you're doing more strenuous exercise, you can do 75 minutes per week. It's very important to reduce the amount of alcohol that you take. If you can go to no alcohol, all the better. But for the people who have to have a drink, make sure that you're having less than one drink per day. But really, the trends of increasing alcohol, we're starting to see more and more alcohol-related issues in women, including breast cancer. Now, another thing that we see associated with increased risk of breast cancer is unopposed estrogen. So if you started your period really early, or you had menopause late, or after menopause you were taking some hormone replacement, those factors can increase the risk of breast cancer. Okay, you can't change all of that, but some of the things you can change are, if you're choosing to have children, having children before 30 does help to decrease your risk of breast cancer. And to a certain degree, the more children you have, the more breastfeeding that you do, there is decreasing risk of breast cancer. Again, these things are not always within your power to do, so I don't want anyone to feel pressure in that sense. But if it is within your power, I would advise people to look into that. For the people who are at higher risk, okay, because of a family history, because of a genetic mutation, or sometimes because of a biopsy that showed a high-risk lesion. One thing that I'm really proud of that we do at MD Anderson is that for some of these women, they may be able to take a certain medication that can reduce your risk. That is something that's available to some women in these scenarios. So this is why it's good to have a good team relationship with your primary care physician and with your team that's taking care of you, so that we can maximize that risk reduction. Some women who are at higher risk, in addition to having an annual mammogram, may also have additional screening with an ultrasound, with an MRI, as a way to also keep on top of their health. Some women who are extremely high risk will choose to undergo prophylactic mastectomy, that's having both breasts removed before a cancer can even have a chance to develop. The reason I've laid all of these options out there is because I want you to have a conversation. There's no version of this that you're thinking about that is off the table, okay? There are options. We want you to be proactive. We're going away from Breast Cancer Awareness Month into Breast Cancer Action Month. So let's take some of the actions we can to try to reduce the risk of breast cancer.
Awesome. Dr. Poindexter.
Well, I believe most of those questions were answered, and that was really thorough response. And I totally concur with all of that. And I'm going to go back to, I just want to reiterate again about, in the encouragement among the community, encouragement talk about, what they're experiencing. You're right. There are stigma sometimes around, especially we talked about pelvic floor disorders, loss of urine. I try and screen every woman who comes in. In fact, it is, in fact, I think I've diagnosed 3 this week that have had atrophic changes, and they were having recurrent urinary tract infection. And I loved hearing that conversation about use of estrogen, because that was the recommendation. And so these things, a lot, we can work towards action on them, but we can't, a lot of times we cannot, the provider, physician cannot do it on their own. We need the conversation to occur as well. And I'm just going to make mention that I love what I just heard about. You should see your doctor and yourself too, because if you can't have a conversation with your doctor, that's not the right one,
Correct.
And I know I get in trouble all the time for having long conversations with my patients and cycle time. And we all know about that, right? But I mean, I think it's important. So they confide in me, and, they're going to get a solution by the time they walk out. So I think that's just very important, as we move into anything, so that we can create action for everyone in our surrounding community to be healthy.
Dr. Jackson, I know that you were not talking about, but the risk of breast cancer, but I'm pretty sure there are risk of like your bladder cancers or whatever. So any risk, because one of the things that I'm seeing as I hear you all talking, it seems that because everything has to do with our hormones, it seems like the breast and the other bottom area can somehow be connected.
Absolutely. In terms of your point with bladder cancer, that's thankfully very rare in women. It's more common in men. However, if they notice blood in the urine, they're smokers, and they're older, age also is a risk factor for that, then they will definitely need to see their urogynecologist or urologist to be able to screen you and to have look for further evaluate you. Okay, so that is a small risk, but thankfully not large for women. But in terms of the hormonal changes, then that is definitely something that is a tough balance, right? Because patients really feel a lot of difference in their body, in their relationships, and with the loss of estrogen and hormonal changes after menopause. And so they do seek the replacement therapies, the oral type or the patches or the pellets. And they often ask me about that. I don't prescribe those. That's just not a need for pelvic floor disorders. The vaginal estrogen is plenty, and it does its job very well at a low risk. And so I do encourage them to speak with their OBGYNs or their menopause specialists if they want those treatments. But thankfully there are, and Dr. Poindexter, please can speak to this point, there are non-hormonal options these days that can help them with, so you do decrease a lot of those extra risks that are involved. So it's something that I think we have to embrace, that we've lost, and find the safest, easiest ways to replace those hormones to help us with these many issues.
So one of the things that if I had to do a review of our whole meeting, it's been that thank God that the science has got to a point where there is something to do. The most important role is on the patient. in the sense of early detection of paying attention to the red flags in our bodies, to going out to these doctors to communicate what exactly is going on. That way, if there is something can be done. And you all are preaching to the choir. I am a realtor who's always on the run, and asked me if I had gone back to get my mammogram. No. So that's the first thing I'm going to do. I had been talking to Jessica Drake from Community Health Network, because she's one of our ambassadors. And she's been saying, Noelia, you need to make an appointment. Noelia, you need to make an appointment. So that's what I'm going to be doing. But honestly, and I know we're being recorded, but one of the things that I don't like is the fact that I don't have much, and what I do have becomes a pancake. And it's like, oh Lord, this hurts a lot, but I know it's good. Has that by any chance improved?
So thank you for asking. The reason, let me first explain the rationale. Okay, I have to defend us. We don't want to hurt you, but we want to find cancer. Okay.
Yes.
The reason that we do this is because we want to smooth out your soft, normal, natural breast tissue so that the hard, lumpy cancer sticks out.
Mm-hmm.
So that's what we're trying to do. But the process of compression is actually always being worked on and improved. We're always figuring out technology to do it a little bit better, because we want our patients to be comfortable so they keep coming back. So you also have the option when you're having your mammogram to do what we call patient-controlled compression, where you're working with the technologist to say, okay, a little bit more, a little bit more, a little bit more. Let me take a breath. Okay. And then you can say, okay, stop right there. I can't take anymore. So we want you to, again, be a team member with us. For women who are premenopausal, they may find that they're less sensitive on certain days of their cycle. So you may be less sensitive. It may be less tender right after your period versus right before your period. So
Correct.
You can schedule your mammogram around that. And that's one of the things I'm grateful for, because we have an online scheduling just at mdanderson.org, breast online scheduling. You can actually pick the day ahead of time to say, this is probably a day that works for me. It's also exciting for me because we have the opportunity to perform breast exams and mammograms on Saturdays as well. And so for people who, like you, are busy, we're all busy, we're juggling all these things, you now have an opportunity to come in on a Saturday without having to coordinate time off work, or, you know, who's gonna watch the kids, or all those other responsibilities. So we're trying to work with you all the time to make it both easier logistically to come in, but also easier physically to go through the mammogram.
Awesome. One more question I have, because I've heard this, that it's pretty typical, is when a woman has a partial hysterectomy, a lot of times there is no need for a pap smear. Correct, Dr. Poindexter?
Yes, you know, sometimes we have to ask the patient very carefully, also the exam, because partial can mean something different to patients and or to persons, to the lay person, than what it would mean to the medical person. Some hysterectomies, if you still have your cervix, then you still need your pap smear. Most of the time your cervix has been removed, and it depends also if you have had another prior history of whether or not you should continue pap smears. So basically, if you had a hysterectomy for benign disease, then removal of the cervix, then no, you do not have to have a pap smear. But I'm going to go back again to encouragement of saying wellness exam. Because when you use the word pap smear, if a woman, what I've noticed, when they hear you don't have to have a pap smear, then they don't come back. So we consider it a wellness exam. And what I have over the last probably 3 to 4 years has been more so your wellness exam. And let me tell you what your prevention is this time. And that way, you know, they know that, okay, do I need a pap smear this time? Has it been 3 years? Has it been 5 years? Is it time for my, you know, mammogram? Is it my Tdap? So I try and help guide them through their care so they can help self-manage themselves. But you know, just sometimes people will, they just associate a pap smear with the exam. And so to get people back, I have trended toward wellness. And that's what it is with ACOG as well, is a wellness exam.
And the reason why I say that is because in the past, women would go get their pap smear and get their mammogram. And then once they're told you don't need the pap smear, well, forget about the mammogram. And that's where I believe that things are, you know, things are being lost in the shuffle there, that it's like, okay, yeah, you may not need this, but now I can see, you know, when you say the importance of the wellness exam. So I think that if nothing else, you can call it a physical. Just make sure you have your yearly physical, if that's the better way to say it, just so that even more so as we get older, we probably even needed more the physical or the wellness exam to make sure that everything else is functioning the way it should. This has been awesome, ladies. This has been great information. I am so glad that we recorded everything. I'm more than sure that we answered pretty much all of the questions that I had here. And gosh, I could be here another hour or so, but I mean, I greatly appreciate you all because you guys took time on a during the week, which is probably your clinicals are probably the most important time during the morning as well. And yet this is gonna, like I said, this is being recorded. This information is staying within our system so that people at their own pace or at their own time can go back into it and be able to listen to the recording. And hopefully, I'm pretty sure that we've answered a lot of their questions. At this point, if you can put it in the chat, and also if you guys want, we still have I believe about 5 more minutes, just where everybody can share what is the best way to access each and one of you all's entities, so that if anybody has any questions and say, okay, this is it, because usually we say, oh my gosh, I was thinking about this and I just heard this must be a confirmation that I need to get something done, so that they can know exactly how to get a hold of each of your entities. So whether they would have a urinary problem, whether they may have a question about a mammogram, whether they may have, you know what, this situation may be serious, what can I do? They will know exactly how to get a hold of you all. Miss Dania, I know you're there, right?
Yes, ma'am.
Anything else you can think so? This has been so awesome. I had been in another roundtable with also MD Anderson Cancer Center, and I love that other one because we had a nutritionist. And I learned that all I'm supposed to eat is what fits in my hand, but in my palm of my hand, I'm afraid that I eat all that it's in my whole hand. But it stayed with me. That's what's important. When she said, you're only supposed to eat what fits in the palm, I said, I'd never desire to have bigger hands than I do now at this point. I said, but it's also such great information, because something always stays and it's right there to remind you. So again, there are no words to appreciate what you all are doing for our community. Like I said, I know our Hispanic community tends to be more on the silence, on the mute side. And we're hoping that by presenting all this information, it become a lot easier for them to reach out.
Thank you so much for putting this together. Thank you for giving us an opportunity to just interface with the community. This is a wonderful organization. Thank you.
Miss Tanya, do you have anything else that we need to do? We got all the information. We're pretty much, everybody turned in their phone numbers, correct? So that we can put it on the website once we download the video.
Yes, and I think honestly, there's not a lot of questions left because it was a great session. Thank you very much. I mean, it was very informative, especially this month of October that we're trying to raise awareness. Detecting cancer on time, it's, I guess, the only tool that can save your life. No matter like what treatment you can get, if it's not detected on time, then pretty much, you know, all your chances are gone. So detection, early detection is the key. So thank you so much. It was like you touched a lot of points that as women, we maybe don't ask all the time, but you were thinking, oh yeah. So yeah, thank you very much. You did a great job. We really appreciate you taking the time. So thank you.
Well,
And
ladies, until the next one, hopefully we would have an opportunity, depending on the pandemic, that it would be nice to be able to have forums where we can have the people present, because I'm pretty sure that if that was a situation, many people would rise up and you're like, oh my gosh, these people have problems. And this was more like an open situation where they would open up. So I am praying that through this recording, people would just reach out, listen to it, and seek help.
If I could say one more thing, and actually, I really want Dr. Tom, it's Oma Foye. Yes. So I would like for her to make a comment real quickly on the 5-year cancer survival rate. I don't think we heard that. 10 years cancer survival rate. I understand they're 90%, like 5-year. So I just want people to have hope that there are treatments out there, not just, even if early detection is the best, but there's still good survival rates with all of the advancements we've had. So I think that's a good way to close.
Absolutely. Can you all hear me? Yes.
Yes.
So, yes. So thank you for pointing that out. So there are different kinds of breast cancer. Not all breast cancers are the same. And the truth is that over the years, we're discovering more and more therapy, and our treatment is going by leaps and bounds. The best scenario is the best scenario is to not have it, but the best scenario is that if you have a screening mammogram every year and it's detected on one of those screening mammograms way before it can be felt, that has the best chance of treatment and survival. And in that scenario, an early breast cancer detected by screening mammogram, the 5-year survival rate is greater than 90%. For a lot of those people, it's 95%. So that is really encouraging information. We're very capable at treating it when it is discovered by mammogram before it is felt, and by frequent mammograms, so not taking gaps in between. So there's a lot of hope here. Don't think about the worst case scenarios or what you know that happened to somebody 30 years ago, 20 years ago, even 10 years ago.
Correct.
Certainly don't think about the scenario in which the person was uncomfortable and didn't come to treatment for a long time, and you're talking about something that had a chance to spread. An early cancer that's detected on screening mammography on an annual mammogram has a very high rate of being treated and cured with a great 5-year survival rate greater than 90%.
Thank you so much.
Thank you so much, Dr. Poindexter, for pointing that out. I think
that
that's
is
very
great news.
important.
Yes, because it's true. One of the things that as Dr. Poindexter said, it's important for them to know that there is something to be done and there is always hope. Because people, the minute they hear the word cancer, their whole world comes tumbling down. And they're like, you know what, is there really any hope? And there is hope, because we see it. I remember my very first time visiting MD Anderson Cancer Center was in 1991, when you all were only one building. I took my mom. My mom died pretty young at 61. She had multiple myeloma bone marrow cancer. And I've seen through the years how everything just has evolved, and there is so much hope. There's so much hope of what to do. The important thing is to speak up, to do the wellness checkups, and to not take anything for granted. Yes. Thank you so much, you all. I think that we're right. Oh my gosh, I've gone 2 minutes over. Gina's going to say what's up with that, but we're done. We're excited. Thank you so much for the great information. And we look forward to doing many more wonderful things in the future with each and one of you all. God bless you, and thank you for your time.